Kia ora koutou. Welcome everybody to today's Bioethics Centre. It's my pleasure to introduce our friend and colleague, Ben Gray, who's an Associate Professor at in Wellington. And I know that this is the topic that Ben has thought about over a number of years, about the way in which the Health and Disability Commissioner's Office and the complaints process can feed into quality improvement. And there was recently a call for submissions on the review of the HDC code, and I'm betting that Ben wrote quite a bit, so we might be about
I need to do.
Take us away, Ben.
Yeah, hang on a minute. Just let me finish fiddling with some stuff. Is that okay? I've got two audience here in Wellington, which is great. Okay, so just the obligatory conflict of interest slide, of which I have no particular conflicts other than being me. So in short, the sort of summary of what I want to do is just sort of talk a little bit about the history of the Health and Disability Commission and where they came from, talk about some of the current role of the Health Quality and Safety Commission and the current role of ACC in managing treatment injury, and then look at what the intersection between all these organisations are and with the HDC and how we might move forward from here. And as you say, John, I've been thinking about this for a long time, and this was really just for the philosophers in the room. Is there any difference between a quality decision and an ethical decision? Because it would seem intuitive that we want both of those things, but they come from different paradigms and different approaches, and they don't always seem to line up, in my humble opinion. So that's part of what I've been thinking about in terms of coming from this. Now, I'm not sure how many of you know much of the history of quality improvement, and so I'm just going to do a very quick run through a couple of things. And we learned an awful lot from the aviation industry. And the aviation industry, the mortality rate in pilots was enormous during the Second World War. And it was still pretty high as things moved out of the Second World War. And there was an important episode where a plane hit a hill. And people died, and it was all terrible. But the interesting thing was that there was another pilot who said, "Oh, I nearly hit that hill last week. But I didn't report it, because if I'd reported it, I was within 100 meters of the ground, and I get struck off from being a pilot if I fly too close to the ground. So I didn't want to tell anyone about it." And so this was when the sort of penny dropped that you need to separate out the sort of disciplinary stuff from the reporting stuff, because unless people report all their near misses, you haven't got the possibility of avoiding the sort of major catastrophe that happened. And this was one of the things that aviation has developed from then. And the idea of a reportable event was created that, you know, it may be that nothing happened, or it may be something terrible happened, but we need to learn from all of the opportunities that we have. And there are a couple of things that came out of this. And one that they talked about was the importance of separating a quality investigation from an investigation that finds fault. And this is really the sort of center part of what I'm really talking about here, is that I think HDC is sort of caught somewhere in the middle between those two things. And in aviation, this is from the Civil Aviation Act in 2023, by law, you cannot use the content of the so-called black boxes on the plane for anything other than quality improvement purposes, unless you get a court order specifically allowing you to do it. Because what they worked out was that if actually it could be used to sue you, all the pilots just turned them off. Because they just didn't want people gathering all that information about what was going on for fear that someone would sift through it and sue them for something. So it's an important principle that they developed within aviation, that actually you can't do both things at the same time. So we've got the Health Quality and Safety Commission, and they have adopted the triple aim, which comes from the international quality improvement literature and is widely talked about. And just to make it slightly easier to read, it has these three aims of the aim to improve health and equity for all populations, the sort of individual patient experience, patient outcomes, and the best value for public health system resources. And then there's been some other literature which I really like, which says, well, hang on, if we're talking about a quality system, don't the clinicians matter? If the clinician's experience isn't going well, then that might lead to less quality outcomes. And so there's a bit of debate about whether we should be including the clinician experience in this. And if you focus on the HDC in relation to this, the HDC is very much in that bottom right-hand corner of an improved patient experience. The rights are all about the rights of patients. And yes, there's the qualification in section 3 about within all the circumstances that they talk about. So they certainly want better outcomes for the population. That sort of goes in there to some extent. The lowering of costs is not something which is really within the ambit of the HDC. And then the clinician experience, there'd be a lot of clinicians, and I've talked to many of them, who are of the view that HDC actually undermines the clinician experience, that the whole process of being complained about and the way in which that all runs is something which actually makes it harder for clinicians. And just as a little reprise from a previous talk that I gave you all, it seems to me that you can't have a quality system unless within the system you've got an educational process. And so as one of the values that we need to do, and you'll recall that I was debating the question of whether patient experience should be equal to rather than superior to the need for education in a previous talk. But anyway, so I think the central problem here is that if we're saying that a quality system is these things, the HDC's set up predominantly to look at just one of these and to sort of take account of some of the others. So just very brief history, which you all know, but established in 1984, code in 1996, response to Cartwright. And at the time, it was groundbreaking. And those of you who weren't around at the time, I mean, at the time, the Medical Council was in the pocket of the New Zealand Medical Association. If you had a hearing before the Medical Council, the disciplinary tribunal was drawn from members of the New Zealand Medical Association. There was no set of standards. There was nothing really guiding what happened, and very few people were found guilty of anything. And so there wasn't a lot of confidence within the process of dealing with accountability. And of course, this was a central theme of the Cartwright inquiry, was that, you know, Prof Green was doing some bad things and the profession was unable to do anything about it. So at the time, it was a really important step forward. And they set up a complaint process. And at the time, again, complaining was a thing which got avoided. People would shove it off, no one would take any great notice. And the idea of quality improvement didn't exist at that time. It really developed around about the turn of 2000s as an idea. So it was brilliant at the beginning because all of those other things weren't in place. And part of my argument is that since then, a whole load of things have changed. And some of the change, so the Health Practitioners Competence Assurance Act means that all of the members of all the registration authorities are actually appointed by the minister rather than elected by within their professions. Now, yes, there are elections that held, and yes, for the Medical Council, 6 of the positions are appointed as the result of an election, but there are a whole load of other members on the council, and they do things to ensure representation of the community and to ensure some ethnic balance, Māori balance, and balance across the different parts of the profession, but also lay members. So it's changed a whole load from the days pre-Cartwright. ACC also changed significantly when they changed from medical misadventure to treatment injury, and I'll talk about that a bit more in a moment. And then the Health Quality and Safety Commission was established, and its job was to look at quality improvement. So things have changed since we originally set up the HDC. Now, oh, this is slid on the slides, I'm sorry. So Health and Disability Commission does complaint resolution. 6,000 complaints were received last year. All of complaints must go to the HDC. You cannot, as a patient, complain direct to a registration authority about the conduct of a health practitioner. It has to go through HDC, who can then refer it to the registration authorities. And that's one detail which I think is a hangover from the Cartwright times when people didn't trust the registration authorities. But it means, for example, at the moment, if there's been a person who's complaining about, for example, sexual impropriety, that sits at the HDC until they send it down to the Medical Council. And the Medical Council does all the investigations on those, but it's just a step in the system which just delays the process somewhat. And curiously, if I, as a practitioner, wanted to complain about one of my colleagues, I can complain directly to the Medical Council. But if the patient involved in the same problem wanted to complain about it, they'd have to complain to the Health and Disability Commission. So there's some weird inconsistencies going on. So they have an advocacy service which does a sterling job of, people ring up saying they're a bit unhappy, and they'll have an advocate who'll help them work through what it is that's troubling them, what they might do about it, what their options are. And they do a lot of education and promotion meetings, and they do around 156 investigations a year, which is, a small proportion of the total number of complaints. And they make quality improvement recommendations, and they determine whether a breach of the code has occurred in those investigations. And then they refer to proceedings. So these are the ones that are referred either to the Human Rights Commission or to the various registration authorities to be considered before the Health Practitioners Disciplinary Tribunal. So the Health and Quality and Safety Commission has a sole function of quality and safety. So all of its investigations are by definition no fault. They do not come up saying someone made a mistake. They come up saying this is how we could do something different, which might lead to a better outcome in the future. One of the things about it is that it's a comprehensive system of complaints, but also adverse event investigations, and it does policy development, and it's a requirement of practice accreditation in many of the professions. So one of the things that HQSC has set up is a whole system of how to run complaint systems, how to do reportable event systems, training of people to do that. And so, in my practice at Newtown Union, we absolutely had a reporting system. We had a process for how we dealt with it. We had a system of reporting back to people about what we'd learned about it. And this is mirrored throughout all of the registration authorities. It's part of what HQSC has set up. One of the things about HQSC is that it's not that what HDC does in quality improvement is necessarily all a bad thing, but the thing is that it's focused according to who complains, not according to what we think is the area which next needs the most attention. And I think that's another important issue which we'll talk about. And then actually at the college conference, College of GPs conference, Don Matheson, who was one of my colleagues at Newtown Union a long time ago, now chairs the National Review of Avoidable Deaths. And so they have a whole process for looking at all avoidable deaths. And it gets very little media coverage. So you don't often get reports about HQSC having found something or other. It tends to get sort of a bit lost in the midst of it because it's not as, well, clickbaitable, I guess, is the way I might put it. And this is their policy on adverse events, which I think I highly recommend that it's worth going and having a read through, because it's a really well put together document about how we should be dealing with these sorts of things. So HQSC has been set up and has been working for a long period of time about looking at quality stuff. Now, the next change was treatment injury. And so the same thing applies here, that you might be complaining to HDC about a treatment injury issue. The example here I've used is about surgical mesh. And the thing is that ACC, because of changing from medical misadventure to treatment injury, and because someone who has got a claim before ACC is able to access services in private and expedite the sort of mitigation, if you like, of their injury, we've had a massive increase in the number of claims put before the ACC treatment injury. So prior to treatment injury, the numbers per year were around, I think it was 600. I haven't written it down on this slide. No, 392. I have written down on the slide. And it's gone up to 11,000. So that's a whole database of people who have sustained a treatment injury. And so it is tasked by its law and by its funding to do things to mitigate accidents. So they've got a role to do things and have money to spend on looking at how to prevent accidents, which applies to treatment injury as well. And a good example is that they have got a program currently between HQSC and ACC looking at surgical mesh claims, because they've had 466 of them through this sort of process. So there's another whole arm of things which you might complain about that are being managed elsewhere. And Marie Bismarck did a really important study many years ago where she looked at serious treatment injuries. It might have been medical misadventure at the time, but she looked at how many of those who suffered a treatment injury complained to HDC. And it was I can't remember the numbers off the top of my head. It was a very small proportion, went up a little bit for serious injury, but the vast majority of people who suffer from treatment injury do not complain to HDC. So again, if you're wanting to do something about treatment injury, just focusing on complaints rather than looking at the whole database doesn't make a lot of sense. And this really is a graphic to try and illustrate what I'm talking about, that the non-smiley faces are all complainants. And the thing is, complainants might be complaining in any one of those sectors of the Venn diagram. So there are a lot of adverse outcomes that are happening all the time, and people can complain about those. There are medical errors, there are adverse events, there are sentinel events. And the bit we're really interested in is the preventable adverse events in the middle. But if you just focus on complaints, you'll be putting a lot of energy into things where actually there wasn't anything much that we could change to improve quality. And so that's an important sort of issue about where we skew our focus in terms of quality improvement if we just do it on the basis of complaints. And so just looking at the numbers there, HDC gets 6,000 complaints, ACC has 11,000 treatment injuries, and HQSC is looking at an avoidable mortality of 9,000. So if you're going to do a quality improvement process on a particular set of data, you're better to be looking at the larger data set rather than the smaller data set. So what are the problems? And I think that there are some important issues here. So the first is this conflict between a no-fault investigation and investigating to find fault and whether a breach of the code has occurred. And one of the issues that has been raised with the HDC is the question of whether there should be a right of appeal to findings under that the HDC makes. And appealing findings is all about breaches. It's all about someone has been found at fault and they want to argue about whether they've been found at fault or not. Whereas you don't appeal a quality finding because it's either useful and you'll implement it because it'll improve quality, or you'll decide it's not useful. So that whole rigor of natural justice and appeals and all of that process, which of course then stretches the whole problem out much longer, is not as much of an issue in terms of quality improvement as in a way that it's central if you're going to have a thing about accountability for breach. So I think there's a fundamental problem with HDC getting involved in quality investigation if it's also at the same time doing an investigation into breach. And then I think another conflict is that HDC entirely appropriately has advocates, and they were originally set up because consumers, as they called them then, I prefer the term patients, didn't have anyone advocating for them. They would lay a complaint and no one would listen, and there was no one to help them through the system. And so one of the things that HDC has done very well is to become an advocate for patients who feel that they aren't being well cared for. And that's really important. But it then means if you're making a judgment on the outcome of a particular episode and you're advocating for one party and the other party is not someone you're advocating for, it's very hard to sort of provide good balance in terms of any decisions that you make. So there are a number of other problems. So sorry about the slides that used to be okay, but obviously don't fit this format. The first word that you can't see there is duplication. And the thing is, if you look at the HDC reports, there are many of them that will have in the appendix the report that has already been done under the processes that HQSC and others have set up. So many of the hospital-based things, their incident reporting system have already been through and have reported on that particular case and come up with recommendations as to how they might change things. And one of the things that I think has happened since the HQSC has come in is that we've all become very aware that if something bad happens, fessing up and doing an investigation and talking to the patient and say, look, we're really upset that this happened. We're going to look and we're going to come back and tell you what's happened. And that can all happen in quite quick time, whereas the whole HDC process is a much longer process. So the thing is, a lot of this is already being done under these other points. And the question really is what else does HDC add to an incident event, an event investigation done by the provider, whichever they might be? And there is an answer to that. There is obviously some providers who don't do those investigations well, and there are other places where the providers don't even have a process at all. But for many of them, I think the duplication is an issue. The second thing, which I alluded to in terms of the mesh harm, is just the whole thing of quality improvement on a single episode compared to looking at 466 cases and coming to a conclusion about what you might do is not a useful use of time, because it may be that from one episode you might come up with one particular conclusion which isn't generalizable to the broader examples of what's been going on. So I think that problem of it being inevitably single episode focused. And another example of that, which I found interesting, and has been a change probably, I think, in the last maybe 15 years, that I was once a witness before the Health Practitioners Disciplinary Tribunal of a practitioner who was found guilty of medical misadventure or malpractice or whatever, based on one clinical case. He missed a diagnosis. And as a witness, I was saying, well, you can't really decide whether he's competent or not based on a single case in many settings. And that if you want to know about his competence, you really should go and look at the rest of the practice. Well, what happens now with the medical council is that if I, as the colleague of my medical partner, complained to the medical council that they'd missed a particular diagnosis, the medical council will put it through its processes, and if they thought my complaint had merit, they would send a team to visit the practice of 2 doctors and a layperson to do a global overview of the practitioner's practice and to decide whether anything further needs to be done. If exactly the same complaint was made by a patient, it has to go to HDC, and HDC only has authority to look at that one episode. They can't look at the global competence of the practitioner. So there's a problem with just focusing on single episodes if you're wanting to do quality improvement stuff. I think that whilst, as I say, Section 3 has the qualification about resource availability and reasonable circumstances, it seems to me, without having done a thorough and representative sample of HDC cases, but there are a number I've come across, particularly a couple from Palmerston North, where the case was about a patient who had a sore back, and they declared a code red on the ED because the corridors were full up with people and she didn't get ideal care. And making a judgment about whether that was a breach of the code or not is a bit hard to do if you haven't looked at the other 39 people who were also waiting and not getting ideal care. And it may have been that the best thing was for her to get bad care so that someone else lived. But that wasn't included within this report terribly effectively. And then I think the other thing in terms of quality improvement, that in terms of the HDC's recommendations about quality improvement, they don't tend to make recommendations very far from the front line. And one particular case that, well, there's a couple of them of rural practices. There was one on the West Coast where a woman was late in having her chest malignancy diagnosed. She was seen by 7 different clinicians in the time leading up to her diagnosis. Initially, they felt that her cough was due to her sinusitis, which she objectively had. She'd had a CT that showed that she had a chronic sinusitis. And it was, I think, some 4 months before someone did a chest x-ray and demonstrated her lung cancer. The central thing was that every one of those people that saw her were locums, were filling in for the time. And there's no way that they were going to be able to read all of the notes prior to seeing each person. It was one of the things which was a problem about the fact that we haven't funded and resourced rural practice over a long period of time. And it's the rural practitioners talk about this at some length, but this wasn't one of the findings in that particular HDC claim, which I thought it could have been. And then there's the problem about quality improvement for those who do not complain. And those of you who know me well is that I'm particularly interested in people who don't speak English very well. And my calculations have been, and it's pretty hard to get this data because no one actually keeps data about who needs an interpreter, but it's around 5% of the population. And there's no funding in general practice. We're about to publish a paper showing that every patient that was seen at Sam Merton's practice, the practice was subsidising the government. It was costing them money to see the patient because of the costs of employing the interpreter, the extra time it took, and the whole issues of caring with someone who needed an interpreter. So it's a big issue. but there's been no breach findings about the failure to provide adequate communication and all of the time that the HDC has been in place. And without communication, you don't get information, you don't get consent, you know, so many of the other rights aren't present. So it's a measure of, if you rely on complaints, there can be some important things that get missed. And then, of course, it's about complaining about service. If you've had no service, it's quite hard to complain. And there are all of these people who now have no registered practice in primary care. So if you're going to look at quality improvement, actually the people who are getting no care surely should be at the top of your list of where you put resources to work out how to improve care, ahead of those who are, you know, have got far enough to be able to complain about something. And I'm not saying you shouldn't do both, but I'm just a matter of where do you put your priorities of putting resource to consider this stuff. And then this reads, report written by a non-clinician. And the people who write the reports, the commissioner and her associate commissioners, are predominant. I don't think none of them are an active clinician. I think one of them may have had a clinical background. But there have been a couple of cases where actually they just didn't get it. And there was a really good example about suicide assessment, which actually Giles Newton-Howes gave them an expert opinion saying, we're lousy at judging whether someone's going to kill themselves or not. And yet there was an expectation that that was something that should have been done by the service, and just didn't understand the literature despite having got some advice. And then there was another case in Palmerston North, which was about a woman who was admitted with chest pain, who'd had a troponin T test and was discharged home, and she had a heart attack at home the following day, and there was dispute about whether she should have been admitted to hospital. And within the detail of the case, they described how she'd had a second troponin T test. Now, any GP and anyone who works in ED knows that the way that we use troponins is that they're not completely sensitive. You'll get some false positives. And so what you do is you take a second troponin T, and if the troponin T is rising, then the likelihood of it being related to a myocardial infarction is much higher than if it's static. And in the report, they sort of said, and they did a second troponin T, and they didn't say why. And it was sort of, oh, we all know why. And then I think there was another case of which hinged around a man who had metastatic prostate, who had had a malignant prostate removed surgically, and they were to monitor by looking for a PSA result. And the important finding in this was that the man had the test done and came back with some positive results that were reported to be within the normal range. They came on a lab result which was in the normal range of a PSA, although the clinician the urologist had said, I want to know if he ever gets anything positive, because the normal range for a person who's had a total prostatectomy is 0. If there's any PSA, it means there must be metastatic tissue somewhere, because all the original tissue is gone. And so the major failing here was that the normal range in the lab was not correct and could be fixed. And it was something which the practice had picked up, but which actually didn't end up as being any particular recommendation, when in my view, looking at that case, it was something where we could have done something which had made a difference, which wasn't followed through. So I think there's some issues in terms of having this done by a non-clinician. And I think that also speaks to what happens with these event investigations, is that they're done by the people who are involved. And the best people to work out, well, what could we have done differently or better in this case, are the people who are actually involved and who could say, if only this had, they're the ones who are best like to pick it up. Whereas someone from the outside may miss, and this PSA one I think was a really good example of some detail which actually was crucial and which the locals had worked out, and they had been talking to the local lab about whether they should change anything. But it seems to me that this is a national thing which could easily set up a new normal range for this setting. We could do it, but it didn't ever happen. So I think there are some important issues there. And then one of the other things that a recent case that Peter Moody commented on in the college documentation was that at one point the Commission was making recommendations about what practice management system the practice should be using. Well, that's a big budgetary cost. And yes, it may be a useful thing to do, but it's not something which makes any sense unless you decide as a team that's working there, okay, we need to do that because that's really important for us. So I think there's some issues in there. So part of why I'm doing this is because we know that the HDC is under a lot of pressure. I've got every sympathy for them. They've got a long waiting list. You know, there are lots of people in the waiting room. There's a large degree in concluding reports, and of the ones I looked up until July 24, you know, it was, I think a majority of them actually were lodged prior to 2020. So it had been in the system for 4 years or so. There've been an increase in volume in complaints that the Commissioner has talked about. There's up to 30% more. And surprise, surprise, many of those are about delays in receiving care. We don't really need an HDC report to say that there's delays in receiving care. And then the budget has been cut. So this didn't receive a lot of publicity, but if you go to the appropriate website, you can see that under the budget of this year, they received a cut in their funding. And so there's something needs to change. I don't think tinkering at the edges is going to solve many of these problems. And so I think that HDC has a central role in complaint resolution and is a brilliant task to do because complaints are all about people losing trust in the health system. And if we don't deal with them well, we don't enable them to get back within trusting the health system and therefore receiving good health care. So it's really important that we do our complaint resolution really well. And the HDC is the only national organisation that's doing this. Now, yes, it's happening at the local level, and that needs to keep on happening. There's some tinkering to the Act where, at the moment, the Act suggests that HDC should be the first place to lay a complaint, whereas actually we should be encouraging everyone to complain as close to the source of the problem to see if we can get it resolved locally. But it's really good at complaint resolution. And I'm arguing that actually they're not very good at the quality improvement. We've got a whole organisation that's designed to do that stuff. That the focus of the problem is, many of the problems that people are complaining about, particularly the doctors, is the investigation process that are that 156 that look at accountability and look at quality. And my argument really is, well, you know, maybe the resource spent doing that would be better, firstly, to send the obvious accountability problems straight to the registration authority and not do any investigation through HDC, or look at HQSC and say, okay, look, they're doing a thing on mesh surgery. We'll send the details of this complaint to them to include in that work, and maybe they can include the complainant and inform them of what work's being done around the quality improvement from that. So I don't know what exactly the best formulation of these organisations working together, but clearly there's an overlap between what HQSC does, what the registration authorities do, and what HDC does, and that it's changed a lot since the code was written, and the activity of the HDC has not changed markedly in that space of time in relation to the other things that have happened around it. So I'm looking forward to, you know, conversations as to how we can make things more streamlined and get a better outcome and a better use of the dollars we're spending on doing this. So happy to take any questions and comments.
So thanks very much, Ben. So I take it that you've got an audience in Wellington as well.
We have two people here, yes, very important people.
We usually take questions from people on Zoom first. So should we do that? Are there any of the people who are on Zoom who'd like to make a comment either in chat or in person to Ben?
Oh, I can stop screen sharing. Thank you. Yes.
Oh, yes. So Nigel's got his hand up. He's discovered the raise hand function. Hi, Nigel.
How to get there.
Thanks. Thanks very much. That was excellent, Ben. And I think it's kind of almost a subtext in there within your slide with kind of the Venn diagram and faces. What it really, I think, underpins the whole challenge is that the overlap between patient complaints and adverse events and medical error is actually quite small.
Mm.
And that's not intuitive. Most of us, and I certainly went through my medical training thinking, if I do a good job, in other words, if I avoid making error, then there aren't going to be any adverse events, and therefore there aren't going to be any complaints. And in fact, that's completely wrong. And you'll be aware, I've done work with medical protection for the last 15 years, trying to help us as clinicians appreciate that fact. And I think one of the interesting things you mentioned was the education side of things. So I think the public need to be educated, and we as clinicians need to be educated about that disconnect, that they don't overlap. And there's a lot to take away from that. So I think the advocacy role of the HDC is really important. But there's also this fundamental, and I'm interested in other people's thoughts about this, why we sort of like the idea of causality. We like the idea that if something goes wrong, there must be someone to blame. And we want to have someone specifically accountable. And in fact, in healthcare, as you some of the examples you gave mentioned of, is much more complex than that. And it's actually really difficult to do that in a reasonable way. So I think there's a lot of education for ourselves and for the public of realizing that trying to explain an adverse event by a causality that holds someone to blame is not necessarily as helpful as it could be. Whereas investigating things to learn from them is almost always a good thing. So I really appreciate you bringing it to people's attention. I'm interested in those things. That awareness that complaint and adverse outcome and medical error are not, they're at best vaguely overlapped. And the second thing about education being important.
I mean, I found a lovely quote in Charlotte Paul's original report on the Cartwright inquiry that was in the British Medical Journal, I think, which said something along the lines of bad things happen all the time. And if you put lay people in control of doing something about the bad things, you'll have troubles because they don't appreciate how often bad things happen. And this perception that you can fix bad things. And it was very prescient of her to say that before all of this got into place. So I think you're absolutely right. And I think that it speaks to a much wider thing, that the thing about blame is very much about, it's this polarization thing. When something goes wrong, actually, the clinicians suffer too, I mean, it's horrible, as any of the clinicians in the room will know. And to then be blamed as opposed to everyone getting together and saying, "Oh, I'm really, really sorry that happened. I did my best and I realize I've got some things to learn," and working out how to resolve that together with the patient and the rest of the community, rather than this process of trying to find out whether someone was to blame and so on, which is, I can be a destructive process.
Thank you. Any other questions for people on Zoom? Okay, how about in Wellington, Ben?
I think that's picking you up if you wanted to say anything.
I just acknowledge that.
Then we can't hear that, so it might be good to repeat the question.
Or you can come up and talk from here, it'd be easier.
Right. I guess you've said the HDC does a lot of good, and well, I can see that. I don't know that we've really talked about the harm that the HDC can do as well. And so we've got really good evidence of harm to clinicians when they've had complaints made about them. The time that it takes to get through the system at the moment, I think, is absolutely nuts. And so I would argue at the moment with the delay that it's not serving many of the needs, and it is causing a lot of harm to patients with the delay, but also to clinicians. And then the consequences of that. I'm an obstetrician, so I can think of a few examples. I won't go in the details, but where ultrasound scans were not particularly accurate, which they're never going to be perfect, particularly as the population gets larger, and people were found in breach. But the consequence of that was they stopped offering obstetric ultrasound in the community because there's other scanning you can do that's a lot easier, and from a medical legal perspective is less risky. So now it's much harder for people to get scans at all.
Yes, thanks, Judy. you're right, there's a whole other presentation I could do about that quarter of the quadruple aim that's about the well-being of the clinician. I mean, one particular area which I've talked about this a bit and had several people come up to me and say, I mean, one of my colleagues at Newtown had a complaint that lasted for 4 years before it was resolved. And she used to do Médecins Sans Frontières assignments, which she was unable to do because she could no longer have a certificate of good standing because she had an outstanding complaint. And there was another doctor I came across who was delayed finishing his College of GP fellowship for exactly the same reason, that he couldn't have a certificate of good standing until that was all resolved. And so he was just left in limbo, wanting to finish this off, but couldn't do it. So I think that, Wayne's other name's just gone out of my head, a long time back. Cunningham, thank you. In Rural GP in Milton, wrote some papers where he did sort of investigations on exactly how much harm people were experiencing as a result of those sorts of complaints. So I think it is a big and important issue. It's not only that they don't focus on it, they actually make it worse in terms of the clinician experience.
Thanks, Ben. There's a question from Simon, but I wondered, are you able to stop the screen share on the computer at Wellington so we can see each other a bit better? So Simon, I'm sure that Ben can multitask and hear your question while he's making with the computer.
Has that done it? Stop sharing. Yeah, there we go. Sorry, the technology is beyond me.
No, you did it. Well done. Thanks, Ben. So I don't have a particular agenda here. I don't consider it like my duty to defend either system, but I would like to understand the conceptual distinctions we're making, and also just to think about what we should be moving towards. So the purpose of the HDC is to protect and promote patients' rights. What I've heard you talk about is the relationship that the HDC has to quality improvement. And as you've talked about, there's a separate commission dedicated to that. Do you see any independent value in an independent agency from the Quality and Safety Commission to protect and promote patients' rights? Or is the conclusion that we don't actually need that? So, and I just want to frame this a little bit further. A lot of the points that have been made could be just taken as, well, there are problems with the way HDC is currently operating, perhaps because it's under-resourced, or perhaps because they're not being thorough enough or talking to clinicians enough. We could perhaps fix all those independently of this question about the relationship with quality. And one further thing, maybe Nigel can help. So there's little overlap between adverse events and medical error. Does that, when we say medical error in that context, does that mean a doctor doing something which is a breach of rights? Did you follow that?
Yeah. Thank you, Simon. You have touched on the bit that I could go off on a huge, great long tangent and talk about my favorite bête noire, America. But I think the issue here is about to protect patient rights, but is this mechanism a good mechanism for protecting patient rights? And part of what I'm arguing is I'm not sure that there's a difference between protecting patient rights and improving quality of care, because surely a patient who gets higher quality care is having their rights protected more than one that's getting lower quality care. And that the rights, that was why my example about communication, there's been a right there ever since 1996 for adequate communication, and nothing's been done about it. So it's been a completely useless strategy for protecting that particular right. And the risk is that it protects the rights of those who already get care, because it's the people who are articulate, who are able to use the system. And I know this isn't totally true, but there's a bias in that direction of the people who are able to complain, get their thing to attention, whereas those who don't have enough money on their phone to ring up don't. So I think it's that thing about whether, and I guess the other thing is in terms of the patient rights, part of what I'm saying is they are important as well as those other 4 things or 5 things. They're not the only thing that's important. And that what I think we've done in a number of settings is we've protected patient rights at the expense of other things. And my current particular gripe is that one consequence of HDC's method of operating is that they take the view that if there's nothing written in the notes by the clinician, then it didn't happen. And so the amount of clinical notes that have been taken over the years since I've been a practitioner have gone from one line per consultation on an A5 piece of card to vast essays that are now needing AI to try and deal with, which means that no one can read the patient notes anymore because there's too many of them. So we've lost the usefulness of a succinct patient record because of focusing on the need to have accountability and have documentation of everything that happened, which then we can't even use the records for what they were originally designed for. So I think it's that the patient rights are important as well as these other things, not above these other things.
Did you want to follow up, Simon?
Well, yeah, thank you. I suppose that issue does sound like a problem, although it still seems distinct from the question is, do we need to oversee patients' rights as well as, which you've actually just said you would do affirm that. I'm thinking about that it's almost a psychological question. If there is no accountability, will clinicians do things which sometimes do things which are wrong? And this doesn't cover all the ways in which things can go wrong in healthcare. It's just a factor. So consider the Herbert Green situation. Would a quality improvement review have done what we needed? I suspect not. Maybe.
I mean, I think I would disagree. I think that the processes that we put in place one of the issues with Herbert Green, and I remember that era very well, there was a completely incompetent surgeon in Hawera who had amputated a 14-year-old's foot as a first procedure after a crush injury that the orthopedic surgeons were incensed about, but they did nothing about it for fear he would complain about them. So I think there's been a whole culture change about people understanding the complexity of healthcare and being willing to examine bad incidents to try and learn how we can do better from it. And I think that whole process has made it much harder for the likes of someone like Herbert Green to go off and do anything, because there are processes where others can say, well, come on, come and have a talk about this. Why are we doing it this way? So I'm not convinced with that hypothesis. I think most of us go to work to try and do the best we can. And there's a very, very few bad eggs in amongst it.
That's the question. Thank you.
So Grant Gillette has a question, and then Nigel.
Well, my question rests on the fact that some of the things you're talking about are at the edge where complexity of the system meets chaos. And at that point, it's extremely difficult to trace causal links. Yet the legal system is totally geared towards isolable and identifiable causal links. Whereas I think in ethics, we need to acknowledge the complexity and create that kind of flexible and imaginative appreciation of a clinical situation which reveals the puzzling prospects that the patient may be facing at any point.
Yeah, I mean, very good, Grant, and you must have read my master's dissertation, which you supervised, because we covered some of this. But one of the things which I haven't emphasized is that there is a really, really important triage process in here. A complaint arrives, someone has to decide whether it goes to the registration authority. Was this surgeon arrived at work drunk and we need to use all of the force of the law to do something about it? Or was it one of these complex, interrelated, hard to find an individual cause sort of problem? Because we can't say that bad things happen and there's no fault and we just have to do quality improvement and that will fix everything, because it won't. And it'll never deal with your doctor deaths and the other disastrous single episodes. So we do have to focus on how we do that triage job. And I think my argument is that I think that actually that's the job of the registration authorities. They are the ones who they set the standard of whether has this person breached a standard which requires significant action, as opposed to HDC finds people in breach of the code and they feel bad about it and it gets reported, but there aren't any substantive immediate consequences. But I think we do need to be very clear that there's a group that actually we need to do a better job of it, and arguably making it easier for patients to report direct to the registration authority rather than through HDC. If what they think is that the doctor actually messed up, they should be able to go straight to the medical council and say, I think the doctor messed up, I want you to do something about them. And the medical council will then deal with that.
So I think we've got time for Nigel and then Josie and Dunedin.
Thanks. I think you're confusing a few things at the end there.
Almost certainly.
Which may or may not relate to the point I was going to make, because back to the original thing, I think the HDC is performing that triage process, and in fact, it's because of that the medical council has been happy. There was 300 went through from the 6,000, because otherwise potentially the medical council would be doing all of this triaging, and it's never going to be resourced to do that. You may or may not think it's worthwhile, but I think back to the rights and why people complain. People normally very often complain because they don't understand what's going on and they haven't been apologized to. No one said sorry. So the whole restorative practice element here is really important. And having that initially dealt with someone other than the regulatory registration body was seen, I think, as a move away from it being a patch protection. We're going to look after our own. So I think the HDC, when well funded, will do that well. And when the advocates do a good job and when we're more responsive to it and see that the HDC being involved will probably involve us early on saying sorry to someone and explaining what's going on and listen to them and worked with them in a restorative way, then a lot of this lower end of things will go away. And then the few things that come through that can be then put through into a bigger system to see the national trends or whatever, can then be picked up by HQ and Z and HQSC and by the regulator. Grant's point was to do with that point I mentioned about causality and us thinking that medical errors and adverse events tie up and are practitioners and how they're working is quite a different thing from why people might complain. And people certainly will complain often about interactional things. And as you say, will maybe not complain when they don't have a voice. And so I think there is a really interesting thing you've raised about the fact that the triage process is still very poor in identifying what's going on and why people might have cause to complain about the quality of care they have. And there's a whole interesting thing about how we collect that kind of information.
I mean, one response I'd have to that is that there have been cases where the HDC has done their report and taken 2 or 3 years about it and referred it to the registration authorities, who then do their own thing. And so that's the sort of thing which, and I guess the point I'm really making, I don't know what the best system is here. All I know is that we've got at least 3 different sorts of organisations that are intersecting, and I think there's problems with the way we're currently doing it. And the question is, okay, in what way might we change it that will improve it? One comment I'd make about the medical council not wanting them, yeah, that's right. They've got to pay to do the investigation. That's one of the breaks on over-investigating less severe cases. You know, that if the medical council investigates something, it costs us as the doctors to pay our subscription. If the HDC chooses to investigate something which is, if you like, trivial is not the right word, but is further away from requiring consequences, that just comes out of their global budget, and there's no particular control over where they set their threshold of what they're going to investigate. And I think that's a question. But I think your comment about the advocacy and the college's submission about this is saying, oh, look, please, when you get a complaint, organise a mediation meeting with all parties as soon as possible. And we're hoping that this will work a lot better than the current processes.
So, Ben, there's a question from Josie and Dunedin, but I wondered if you could just quickly address Jim Ross's point here, which because it's on point. The problem with registration body triaging is that the public may not have confidence in that.
Yep. And I guess part of what I'm saying is that any complaint process the patient chooses to use, if they're not happy with it, they can then go to HDC. So, I mean, I guess what I'm saying is that if people don't have confidence in me as a provider, they won't complain to me either. So I think that HDC is always going to be vital for those who don't have confidence in whichever part of the system they've engaged with.
Thanks. Josie.
Oh yeah, thanks, Ben. That's really stimulating. Some of my thoughts have been covered by Nigel and Jim. I'll just add that it's also the case that people don't necessarily know who screwed up with anyone. They just know that something went wrong and they don't know, right? So you'd have to know a lot. So it actually makes it harder if you have to sort of be the one to figure out who you're complaining about, honestly.
Yep.
But a thing that, like, I feel to me like a lot of these problems could be addressed by better resourcing HDC and having really fast turnarounds and maybe even allowing an almost simultaneous systems to kind of happen and stuff. So it starts at HDC and it's quickly clear that medical council also needs to do something, whatever. But I kind of come back to a really big picture question, which is, I think it would be amazing if New Zealand had a system where people could lodge complaints and we had an incredible triage system. We already have something impressive happening. We're only 2.5% of complaints are actually investigated. So there must be some really good triaging going on and prioritizing, etc. And that was really well funded and really fast. But I also worry that it's just one more example of us wanting a kind of champagne system with not even a bare budget. Like, would we really and truly be willing to pay what that actually would cost to do?
Yeah.
Because that's my sort of big kind of like worry that like we pretend we constantly in this country, I feel like pretend that we can do something on a smell of an oily rag and it's just getting like impossible. So I don't know if we can kind of perfect the HDC complaint system. We might have to think of a way, realize that we can't quite afford what we want. But I do think we want something that's really accessible. So I mean, it's just another problem to add to the mix, really.
Well, no, and I think you make some really good points. And I think some of the responses in terms of, I say, the college's submission, rather than complaining to the HDC, complain direct to the provider and they can organise to meet with you within the week. I mean, you know, the response time stuff is something HDC will always have problem with because it relies on the papers. So, you know, I think it's not going to be HDC that deals with that. And so that I think, and as I say, the Act currently directs people to HDC first, whereas I think changing the educational thing of, you know, this is complex. If something's not gone well, please talk to your provider and they're happy to provide you more information. And that has changed a lot. I mean, the whole point about the treatment injury is that all of those people who've put a treatment injury claim have had someone talking to them about what happened because they signed the piece of paper saying they were claiming for a treatment injury. So there have been changes in that. And I think you're absolutely right that the advocacy thing is really important. And then I think the other thing is it's this polarization thing. If something goes wrong, I must complain, rather than we as a community need to work out how we can do a bit better. And I'm not sure the strategy of lots of complaints to HDC is a very effective strategy to make the thing the next bit better.
Great. Well, thank you all very much. The final thing I should say is that next week we have a talk by Carl Elliott. Is he here in
He'll be
person?
physically in Dunedin.
He's physically in Dunedin. So
Oh, cool.
yeah, if you're in Dunedin, please drop by and see Carl. He's talking about the occasional human sacrifice, blowing the whistle on abuses to research subjects. So thanks again, Ben, and we hope to
Thanks
see
so
you.
much, John. Thank you, audience.
He